Hello, everybody. Welcome to today's webinar, and today's topic is understanding the vestibular migraine. And with me, I have Dr. Amin Kiranman, assistant professor of neurology in Baltimore, one of the best places. I was there, and I really have seen this presentation. I don't know if it's exactly the same, but something like that. That was really, really good, and that's why we have him with us today. Just some practicality. All participants are muted to reduce background noise. It's possible to ask questions during the session using this question box that you have on your screen. The questions will be collected by me, and I will present it to Dr. Amir when he finishes his presentation, and let's see how many questions we manage to get through. If your question has not been answered, we will provide you an answer afterwards. If you have any technical problems or need some support, please write to me. I'm the moderator. So that was from me. Thank you for coming and for showing your presentation today here with us, Dr. Amir. And now I'm going to make you the presenter so you are able to show your presentation, and welcome to the webinar.
Thank you, Mariana. Thanks everyone for having me. My name is Amir Karam and I'm here at Johns Hopkins in Baltimore. This is my email. Feel free to contact me if you have any questions after the talk. I have no disclosures here except that watch for visual vertigo as you're looking at your screens. Let's start with a case. A case that we often encounter in clinics. 37-year-old man with a 2-year history of daily fluctuating dizziness, described as constant jumping in vision along with nausea, worse with activity. His symptoms started as occasional dizziness and gradually became more frequent. He now feels drunk all the time. He's not able to drive or tolerate physical activity. There are occasional attacks with actual spinning sensation that can last for minutes without headaches. He has sensitivity to sound, fluctuating tinnitus in both ears. He has visual discomfort looking at moving objects or computer screens. There are frequent headaches at least twice a month with nausea, vomiting, light, and sound sensitivity since age 25. His mother also gets migraine attacks. There's also a history of car sickness. He has no recurrent falls or loss of consciousness. Neurological history is otherwise unremarkable except for chronic difficulty with sleep. He had an audiogram, brain MRI, and brain MRA about a year ago that were all normal, and the bedside neurological and vestibular examination is only remarkable for difficulty with tandem gait. So this is a case that is not uncommon in neurology or ENT clinics, and often the question is, what is the next step in terms of approaching to this problem, or the next step? So what would you do? Ask for calorics and video head and pulse testing, suspect Meniere's disease, and ask for a repeat audiogram, or based on the story, just diagnose vestibular migraine and prescribe OTOMETRICS, or just go ahead and prescribe meclizine. So we're going to hopefully be able to answer this question by the end of this talk. Just to give you an outline of what we're going to discuss today, I'm going to go over the terminology, what is the definition of vestibular migraine, go over the diagnostic criteria, components of the history, key exam findings, just quickly touch on pathophysiology and key points for treatment of migraine. There's a big problem with terminology. People call vestibular migraine different names. You may have heard vestibular migraine, benign recurrent vertigo, migraine-associated dizziness, migraine-associated vertigo, migraine vertigo, and etc. But probably the best term would be vestibular migraine. According to headache classification criteria, the migraine, not just vestibular migraine, is diagnosed based on 4 important points. At least 5 headache attacks that can last from 4 to 72 hours. The headaches at 2 important features, at least: unilateral location, pulsating quality, moderate or severe pain intensity and aggravation, by or causing avoidance of routine physical activity. There are also associated nausea or vomiting, photophobia, and phonophobia. Based on this criteria, migraine with aura would be the same, except that there are visual, sensory, speech or language or motor aura that can at least be with 2 attacks that fulfill criteria B and C. And the aura usually lasts from 5 to 60 minutes, which can be followed by a headache. This can be, this mnemonic can help to quickly diagnose migraine based on the story. SULTANS, you can remember that, the severity of the headache that is worse or moderate. It's moderate or worse. Unilateral, throbbing, or activity can make it worse. And there's also nausea and sensitivity to light and sound. So this is the diagnostic criteria for migraine. But for vestibular migraine, you have the same criteria with respect to the headaches, but the dizziness symptoms could be also associated with that. So at least 50% of the episodes could be associated with dizziness, and headaches could be at least 2 of the criteria I mentioned before: one-sided location or pulsating quality with moderate or severe pain, and there could be associated photophobia and phonophobia along with visual aura. So this is the criteria for definite vestibular migraine, whereas probable vestibular migraine, there is criteria A, which is at least 5 episodes lasting from 5 minutes to 72 hours, and only one of the criteria B or C may exist. And obviously there should be no other findings or diagnosis that can explain patient's symptoms. So what are the symptoms, characteristics in migraine? People report internal vertigo, a false sensation of self-motion; external vertigo, which is a false sensation with visual surroundings spinning or flowing. This could be positional, happen every time that there's a change in head position, could be visually induced, triggered by a complex or large moving visual stimulus, or it could be head motion induced, not necessarily changing the position of the body. There is also a term that is often used as dizziness, which is in general could be thought of a sensation of disturbed spatial orientation. Duration of symptoms highly variable. About 1/3 of patients report symptoms that last for minutes, 1/3 for hours, and about 1/3 have symptoms that can last several days. The remaining 10% of people report these lasting second, only associated with the head motion, visual stimulation, or after changes of head position. Just a note that vestibular symptoms are rated moderate when they interfere but do not prohibit daily activities, and severe if daily activities are disrupted. Just a few points about epidemiology. Most common cause of spontaneous episodic dizziness in a modern life is now vestibular migraine. It has about lifetime prevalence of 1%. The mean age of onset is about 40. Headaches usually precede vertigo by almost 10 years. Women are much more affected and diagnosed with vestibular migraine. There is a bidirectional association, which means that dizzy patients are more likely to have migraine, and migraine patients are more likely to be dizzy. So these are important points to keep in mind when you are encountering dizzy patients. About 40% is the prevalence of migraine in dizzy clinics, specialty dizzy clinics. In headache clinics, about 30% of patients have dizziness or more specifically report spinning sensation or vertigo. There is a familial occurrence of vestibular migraine with the autosomal dominant inheritance documented in several families. Just a Few pearls to remember about approaching dizziness and migraine. Duration of symptoms is usually minutes to days, but low-level symptoms can last days to weeks. So it's not uncommon to encounter patients that report persistent daily symptoms. About 20% of patients may have hearing symptoms, often described as muffled sound, ear pressure, pain, or tinnitus. There's often chronic motion sensitivity. Sometimes people report symptoms that can fulfill the diagnosis of Navier-Stokes syndrome. Migraine headaches are often an infrequent or long forgotten symptoms of vestibular migraine. So it's important to really dig for a history of migraine at younger age. Again, important point is that migraine headache may occur independently of vestibular symptoms and vice versa, so it's important to look for that in the history. Often family history is positive and attacks of vertigo, including in childhood, may be the predominant symptom in some family members. Light sensitivity is common in migraine patients during the attack of vertigo. Panic, anxiety, phobic behavior are also common with vestibular migraine and dizziness. And keep in mind that in children and adolescents, migraine is the most common cause of vertigo. Okay, what do patients experience and how do they describe their symptoms? These are the complaints that you hear often from the patients: sense of floating, sense of unsteadiness, walking on air or pillows, feeling like junk, sense of rocking, fogginess, feel like eyes don't catch up with head and body movement, they can't tolerate head movement, motion, or changing position, feel like seasick all the time, feel like wearing the wrong prescription lenses. Keep in mind that the common characteristics of chronic symptoms are smoldering, fluctuating, episodic on chronic, and you often hear that there are good days and bad days. There are important triggers and very important to look for them in the history: dietary triggers, environment, medication, sleep quality, stress and anxiety often contribute to migraine attacks. This is a model that shows how these different factors can contribute to symptoms in patients. There's a threshold for dizziness and the threshold for headache. So the way that the model works, if these triggers surpass a certain threshold for dizziness, patients experience symptoms. If they become significant enough, they can lead to headache. So you can have days that these triggers do not reach the threshold and patients have better state, and there are days that they pass the threshold and they become more symptomatic. Compared to dizzy patients, non-migrainaires have higher threshold. That's why these important triggers do not cause symptoms in those people who don't have tendency for headache and dizziness. In terms of component of the history, it is important to ask about balance, falls, difficulty with turning over in bed, that sense of motion of the environment, lightheadedness or faintness, look for phobic behavior, look for double vision, ask about the quality of the vision in terms of blurry vision, flashes of light, or jumping in the vision, difficulty with reading and driving. So the parts that are shown in red are the red flags. So if a patient falls or there's a difficulty turning over in bed, there is a faint or double vision or jumping in vision, you should not suspect migraine as your first possible diagnosis. Keep in mind that dizziness is often difficult to describe. An accurate approach would be based on timing, triggers, and associated symptoms. Again, other components of the history that are important to ask patients with dizziness or turning over in bed, whether that can trigger symptoms, walking or standing in the dark or uneven surfaces, being on elevators, escalators, or stairs, motion sensitivity on airplanes, boats, or riding in cars. Sensitivity to sound, cough, sneeze, strain, or laugh, looking at moving objects, being in narrow spaces, or association with having meals. Again, if you have somebody who, for example, gets dizziness with cough, sneeze, strain, or laugh, you should look for other possible causes of dizziness, for example, paralytic fistula or peripheral vestibular problems. In terms of visual triggers, important ones are crowded aisles, big box stores, crowds, fluorescent lights, watching traffic or pedestrians, windshield wipers, looking at the stripes, zigzags, and tile floors, being on bridges, escalators, and tunnels, or looking at the 3D movies or large screens. These are common complaints from patients. Just quick points about the pathophysiology of migraine. There are two important mechanisms. One is linked to the trigeminal vascular system. The trigeminal ganglions is important for innervation of the meningeal blood vessels. Also, increased activation in trigeminal ganglion can affect neural networks higher up, all the way to the cortex, that can lead to symptoms. Another important phenomenon is the cortical spreading depression, which is the transient neural depolarization with a wave that slowly spreads across cortex from occipital area and is often followed by a prolonged suppression of cortical activity. This is linked to aura symptoms in patients with migraine. Overall, recent models propose that migraine is a pathological brain state involving multiple brain networks and is not just linked to specific network or brain location. Some studies show increased metabolism in certain structures like cerebellum, thalami, frontal cortex, and temporoparietal cortex, and decreased metabolism in bilateral occipital-temporal and posterior parietal cortices during the migraine attacks. There's also a possible change in structures, for example, decreased brain matter volume in the temporoparietal cortex, as shown by some studies. In terms of functional aspects, patients with vestibular migraine are very sensitive to visual stimuli. One way to look for it is the raw tilt test. It's a simple test that can be done on a computer screen. The patient is looking at a line and has to adjust it to upright position while there is a rotating visual background. And usually people with migraine are more affected by this type of stimulation than healthy controls. They're also more effective posturally. This study looked into the effect of visual stimulation in patients with migraine and compared that to normal controls and patients with vestibular loss. As you can see, the black here shows patients with migraine that are more posturally affected by the visual stimulation compared to people with vestibular loss or normals. It's been also shown that patients with vestibular migraine have lower threshold to detect tilt. It means that if they are tilted to the right or left, they can detect change in body position much faster and at lower frequencies compared to normals or people with just migraine and no dizziness. Another important aspect of symptoms in patients with migraine and dizziness is related to their spatial orientation. We maintain a stable perception of the world in upright orientation even though our eyes, head, and body rotates all the time. So here is a simple example. If you, for example, looking at a line with a camera, and if you tilt the camera and view the line through the camera, as you rotate the camera to the right, the line moves to the left. Whereas when we tilt our head, there is no perception of tilt. You can imagine that patients with migraine may be more affected by changes in their head position. And in fact, when we looked into this using a measure of subjective visual vertigo and measured patients' upright perception, we found that compared to controls, these people are more affected and have higher errors, at least in one head tilt position, which shows that perceptual mechanisms are mainly affected in patients with vestibular migraine and can contribute to their symptoms. How about exam findings at the bedside in these patients? For the most part, the exam, there's no significant finding. The oculomotor and vestibular examination is normal in these patients. There are occasionally spontaneous and sustained positional nystagmus in these patients, especially during the attacks. Patients often have difficulty with gait and balance, especially with enhanced maneuvers like enhanced Romberg or standing on one leg with eyes closed, but they can compensate for that, and there is often no fall in these patients. Here's an example of a nystagmus, a spontaneous nystagmus in a patient during attack. You see that there is a left beating nystagmus, and we were able to measure this, and you see the fast phase and the slow phases of the nystagmus in this patient. Here's an example of sustained positional nystagmus. So this patient only gets the nystagmus in the static head down positions, and you don't see this spontaneous nystagmus in the head upright position. This is not necessarily a finding during the attack. Patients may have this sustained positional nystagmus in between the attacks. Again, not a specific finding in patients with migraine, but it's not uncommon to see that in people who have no other findings on the exam and are diagnosed with vestibular migraine. Another important finding that you can find in testing is increased duration of vestibulo-ocular reflexes during rotational chair testing. Here you see the slow phases of the vestibular nystagmus in a patient with vestibular migraine. You can see that it lasts up to 30 seconds, whereas in a control, it usually lasts less than 10 seconds. So patients with migraine tend to have longer duration of a nystagmus after rotation, which is, again, a common finding, but not necessarily specific to vestibular migraine. Interestingly, study looked into how whole body rotation can affect vestibulo-ocular reflex and duration of perceptual changes, perception of rotation in ballet dancers. They found that ballet dancers who have a lot of practice have reduced duration of vestibular nystagmus and perception of rotation that correlated with their expertise level and also changes in their brain structure. So if you think about dancers as people who have really good control over their vestibulo-ocular reflex, and migraineurs as people who don't and often have symptoms with daily activities, they have very high level of symptoms and low threshold for dizziness, whereas dancers have low symptoms and very high threshold for dizziness. They'll be at both ends of the spectrums, whereas average population would be somewhere in between. So a good treatment and a proper treatment would be something that can help patients with vestibular migraines move from the end of the spectrum somewhere to the middle. And that's where the different components of the treatment comes in. Usually different medications are used for acute attacks or to prevent the dizziness in these patients. It's important to keep in mind that medications are not the ultimate treatment in these patients. Some medications like TOPAMAX should be used with caution. Often amitriptyline, propranolol, or metoprolol are used to suppress symptoms in these patients. Important point is that medications should be used at a very low dose, and doctors should avoid polypharmacy. And keep in mind again that medications are not the ultimate treatment. So what would be the proper approach to patients with vestibular migraine? This is probably a multifaceted approach to be effective. So important to eliminate provocatives like diet, weight, lifestyles. Sometimes food supplements can help, like riboflavin, magnesium, butterbur. Psychological management, stress and depression management can often help. Biofeedback approaches are very helpful. Activities that can promote eye-head-body coordination and help the brain develop the skills that needs to be more comfortable with the surrounding environment can be very helpful, like ping pong, dancing, and Tai Chi, along with appropriate use of migraine prophylactic medications. These measures can be effective if all addressed in patients with vestibular migraine. Keep in mind about the red flags. So it's not uncommon to see patients develop migraine symptoms as a secondary problem, like a lot of patients with Meniere's disease, recurrent BPPV, any condition that creates sensory conflict like vestibular hypofunction, or patients who have persistent postural perceptual dizziness or POTS may have a migraine tendency. It's also important to look for other causes like immune disorders, mitochondrial disorders, or episodic ataxia or spinocerebellar ataxia that could be associated with migraine. So let's get back to our case. Our 30-year-old Navy man with a 2-year history of fluctuating dizziness, sensitivity to sound, frequent headaches, but no other significant neurological findings. So based on what we discussed so far, it's important to rule out the secondary migraine in these patients. And in our case, our patient had positive head impulses that were not detectable at the bedside. So we could see covert catch-up saccades in all canal planes. This is the right lateral, right anterior, and right posterior, and you see the left side, and these are the catch-up saccades with some marginal gains. He also had caloric weakness, and rotational chair testing showed very reduced VOR gains. So this is a good example of somebody who may have some migraine tendency, but the main trigger for the recurrent daily symptoms is bilateral loss of vestibular function. So it's always important to get vestibular testing even in patients who give you a typical migraine story. Thank you very much for your attention. I think we are on time, and again, if you have any questions and you need to contact me, here's my email address.
Thank you, Amir. I have one question for you. I hope you have time for that. Sure. Why would you do the caloric if you already done the test of the head impulse test on the patient and you are already suspecting there is a migraine, right? What is the caloric adding as information?
That's a good question. Usually people with vestibular loss may have a frequency-dependent vestibular hypofunction. As you know, caloric testing is more like a low-frequency test of vestibular function, and head impulses screen for higher frequency vestibular function. So it's not uncommon to see somebody who has normal calorics and has reduced gain in head impulse testing, or vice versa. For example, patients with Meniere's, they may have normal head impulse testing or findings that they do not show up on head impulse testing, whereas the calorics show reduced responses. So it's important to look for signs of vestibular loss looking at different frequencies.
Okay, but if you had if you start with a head impulse because it's the less yeah, it's more comfortable for the patient. Would you still do, and you have an abnormal, would you still do the caloric to see if there's a problem in the low frequency? Does it add something to your treatment to find out the low frequencies as well?
In patients who have normal bedside examination and head impulse is normal, depending on the story, you may just get the head impulse testing and not go for calorics. But if you, for example, suspect Meniere's disease based on the story, it would be helpful to get calorics. So I would say it depends on the history, and the test can be ordered within the clinical context.
Yeah. Would you add a VEMP to be sure that it's not a Meniere, but it's a migraine?
I usually get VEMPs when I suspect vestibular loss, and I want to evaluate the otolith ocular pathways. So again, it will be more tailored based on the clinical story and suspicion at the bedside.
Okay. Okay. Thank you very much. Now I will take over the screen, and I just want to thank you so much for your presentation. You did it on time, even though you were afraid that you take more time. It was really, really interesting, and I think the reason why I choose that topic for this, it's because people now are asking, I think in the beginning when we launched the head impulse, the questions were a lot about how to use the head impulse and how to interpret the results. And now it's much more about how do I make the diagnostic, and that's why I had the questions I had.
I see.
Because people are really, how do I interpret the data that I have, and what else do I need to do?
Right.
Yes.
Right.
So thank you so much for participating in that, and for all the participants, thank you for taking the time to assist that. There will be a link available by the end of this week, so if you want to see it again or want to send to someone, you will be able to do that, and you will receive the link automatically when you have signed up. Otherwise, it will be on our website. Thank you, Amir. It was a very interesting webinar.
Thank you very much for having me.
Thank you. Bye.